Hi, this is Elliot Fishman, and this talk is going to be on mucinous cystic neoplasms of the pancreas, detection, and patient management. And let me just take one step back first. We talk about different cystic pancreatic lesions. MCN is a very important one. IPMNs, pseudo papillary neoplasms or SPEN tumors of the pancreas. We talk about serous cystadenomas and lymphoepithelial cysts. We talk about a range of cystic lesions, as well as cystic tumors, occasionally adenocarcinoma, and surely cystic neuroendocrine tumors. The key thing is to think about them in terms of number of factors: where they're located, body, head, tail, what's the age of the patient, what's the CT appearance. And we put all these things together, and we can often come up with a very, very accurate diagnosis. So, for example, we talk about mucinous cystic neoplasms, MCNs, and that's what I'll call them for the rest of this talk to save time. We talk about age 40-45. We talk about serous 60 to 70. We talk about SPEN, teenagers and 20s. We talk about IPMNs is usually 60s and 70s. But that's only just the big rules. It doesn't mean anything every time with an individual patient. We talk about looking at cystic lesions. We talk about looking for nodules. When we talk about MCNs, things that worry us are thickened septations or mural nodules. When we look at IPMNs, the same thing. Mural nodules, particularly enhancing nodules, are always going to be concerning to us. With better spatial resolution, it is easier to see these little nodules. And again, with good dual-phase imaging, the ability to look and see whether nodules actually enhance. Obviously, when we get past CT, and this lecture is on CT, we might need to do ERCP if we're not certain. We might need to do MRCP. We might need to do a biopsy to get fluid. On CT, non-complicated serous and mucinous tumors are typically water density. On MR, they have homogeneous hypointensity on T1 and hyperintensity on T2 images. Therefore, the density or intensity of the contents cannot discriminate mucinous tumors having malignant potential from serous benign lesions just based on the density. Now, of course, with serous lesions, we had a talk recently about that. Different types: oligocystic, microcystic, macrocystic, solid lesions. Even if you only speak about serous tumors, they're not all the same, right? There's a range of appearances. And we speak about MCNs. Once something is an MCN, particularly if it's over 2 centimeters, it's always going to be resected. You know, when we see mural nodules, then I'm thinking about high-grade dysplasia. If I don't see mural nodules, I'm thinking about low-grade. But at the end of the day, it's coming out, and the pathologist will be making that answer. We talk about calcifications. Calcifications centrally are most common. That's stellate calcification in serous cystadenoma, often pathognomonic. We talk about peripheral or eggshell calcifications in MCN about 15% of the time, and those typically are more concerning for malignancy. And we talk about things like SPEN tumors, which can have calcifications peripheral or punctate, but there really is no match between calcification with SPENs and the patient's outcome. Remember, with SPEN tumors, if resected, it's over a 90% 5-year survival. We talk about IPMNs, about 20% will calcify. Often it's punctate, but can be coarse calcification. Coarse calcifications were reported to be associated with malignancy in over 80% of cases. But again, these cases also had other features, such as main duct dilatation, solid nodules, or size over 3 centimeters. I don't typically think about IPMNs as a calcifying lesion. Neuroendocrine tumors, on the other hand, commonly will calcify. It can be punctate, it can be more extensive. This article found 16%, but I would say it's probably closer to 30 to 40%. The really tiny neuroendocrine tumors often do not calcify, but when the lesions are larger, then calcification is indeed very, very common. Now, one of the things, of course, we do with imaging, be it CT or MR, is first detect the presence of the lesion and then try to be very specific. We talk about serous cystadenomas, as I mentioned a few minutes ago. There are multiple appearances. We also mentioned they have this circumvascular sign, where people have written articles that because they get very large, they don't typically invade vessels, but they can compress vessels. And the circumvascular sign is the presence of abnormal arteries surrounding the lesion on arterial phase. The thing about the circumferential sign, if you're uncertain if you're dealing with a serous cystadenoma or not, it makes it much easier to reach the diagnosis. Now again, scarring, calcification, circumferential sign all help you be more specific, because all of them adding together allow you to make the diagnosis of serous cystadenoma rather than confusing it with mucinous cystic neoplasm, a SPEN tumor, or a neuroendocrine tumor. So again, one of the things we need to do is try to figure out what are we dealing with. If we're uncertain, then you might go to MRCP. If you're uncertain, you may go to EUS with fluid sampling. So let's talk about MCNs now. We've spoken a little bit about serous and MCNs and SPENs and cystic neuroendocrine and pseudocyst and cystic carcinoma. Well, mucinous cystic neoplasms are septated, thin-walled, fluid-filled cystic lesions. Pathognomonic features include eccentric calcifications in about 15% of cases. It's rare to see duct communication. You can see duct obstruction occasionally, but the communication with MCNs and the pancreatic duct typically doesn't happen. If you sample the fluid, elevated CEA or mucin is typically indicative of malignancy. These days, resection is recommended for all lesions by all guidelines when you think it's an MCN. People have spoken about maybe size. Can you follow them if they're 2 centimeters? Everyone agrees at 4 you take them out, but truthfully, everyone agrees you take them out at any size, because if you take them out, you'll cure the patient, okay? If you leave a lesion in and it does become malignant, then you have a problem in terms of long-term survival. So some more facts. More common in middle-aged females, I mentioned, 40-45. It's typically the mom tumor. Serous is the grandmom tumor. It's in the body. 4 centimeters or more with nodules are more likely malignant. But even under 4, if you have nodules, it's more likely going to be malignant. And again, the terminology by who? Low grade, intermediate grade, or high grade dysplasia. So one of the things, these can be found incidentally, but they also can present with abdominal pain, unexplained recurrent pancreatitis, when they get large gastric outlet obstruction, or even a palpable mass. Jaundice and weight loss are more common when patients have malignant lesions. Again, in terms of diagnosis, cytology will find mucin-containing cells and a high concentration of CEA level. Presentation, we mentioned abdominal pain or weight loss, with abdominal pain being number 1, but also 16% is going to be 1 out of 7 is going to be an incidental finding in an asymptomatic patient. Location. Body is the best place, or body tail. No communication with the pancreatic duct. We mentioned women in their 40s. The microscopic exam, the presence of ovarian-type stroma and mucin-producing columnar cells is classic. It's usually a single cyst, but again, we then look for calcifications, thickened wall, mural nodules, and the like. And again, patients can have a range of symptoms from being asymptomatic to presenting with acute pancreatitis. In terms of malignancy, MCNs are benign but have a high potential to become cancerous. Both IPMNs and MCNs can become cancer. MCN has a higher percentage. Surgical resection, typically distal pancreatectomy, is the standard treatment to prevent cancer progression, and the outcome is excellent if resected before invasive cancer develops. In this article talking about guidelines from Frank Miller, this just reviews a few of the points. MCNs, usually 95% of cases, are in the body and tail of the pancreas, though we've seen some in the head and it can be confusing. The lesions are rare in male patients, though we have seen them. So it is something that can occur in males. It's not only going to be females. Differential diagnosis, pseudocysts, not that typically a problem. Serous cystadenomas can be a challenge, though age will vary. IPMNs, cystic neuroendocrine tumors occasionally are all in that differential diagnosis. When you see the location and you don't see a dilated duct and you see coarse calcifications, I think it's much easier to reach the diagnosis. Malignancy rate associated with MCNs, 10 to 17%. Features associated with malignancy, invasion of local structures, nodes, distant mets, over 4 centimeters, thickened wall, enhancing components, mural nodules often with enhancing, peripheral calcifications, and pancreatic duct dilatation. Now, it does not obstruct the duct, but it can invade the duct. An MCN in a male would have a higher percent of malignancy, but again, it's infrequent. When these lesions metastasize, local spread as well as liver metastasis. So again, very important information. That no communication with the pancreatic duct really helps you out in distinguishing it between IPMN, which always communicates or almost always communicates, particularly when it's larger, with the pancreatic duct. So it makes life a little bit easier. And again, this ovarian type stroma, which is really shown by septations. So let's look at some examples. Let's get started. Here's a complex cystic lesion, body tail of pancreas, lobulations, thickened septations, peripheral calcifications. This is a mucinous cystic neoplasm, and you would have to worry about malignancy. Another patient, cystic lesion more toward the tail of the pancreas, slightly thickened wall. I do not see any definite septations, but there is a thickened wall. I do not see a dilated pancreatic duct. I do not see vascular invasion. You can see a little bit thickening on the coronal in the inferior aspect of the lesion. And this lesion looks like an MCN. There's no calcification. It was taken out. It was low grade. Another example, here you see a case with septations. Almost the same location previously. Sometimes, as in this case, you see atrophy of the distal pancreatic gland. But look at those septations. When you start seeing septations, that's that ovarian stroma. You have to worry about malignancy in a case like this. Again, could it be low grade? The answer is yes, but that's the pathologist's job. And you can see it very nicely here again when you look at the same case in the coronal view. And again, look at those septations. Just a really classic case which you can learn something from. Cinematic is very good because we're able to see the septations better. I'm not sure, we haven't looked carefully, can you use cinematic to be able to say what's low grade, what's intermediate, and what's high grade? That might be interesting because you see the septations better. You can see it here, they look thicker. Here I surely would worry more about an intermediate or a high grade tumor than a low grade tumor. Here it is again on the cinematic in the coronal type perspective, again making me concerned. And here's a few more images. Vessels look good. There's no vascular invasion. And that was intermediate. Another example, cystic lesion, perfect location, body of pancreas, well defined, no dilated duct. Could this be a pseudocyst? Could it be an IPMN? If it was an IPMN, you would surely see a dilated pancreatic duct. it was a pseudocyst, you might see some other changes around the gland. This is a classic example of a mucinous cystic neoplasm, or MCN, of the pancreas. You could think about an oligocystic serous cystadenoma, but the closer you look, the more you do see septations. And when I get those septations and I get the body location, and it's a 40-ish-year-old female, it's an MCN. Another example, could this be an IPMN? The answer is yes. Cystic lesion, junction of body and tail of pancreas, about 3 centimeters. IPMN could be a pseudocyst, could be an oligocystic serous cystadenoma, very sharply marginated, very well defined, relatively small. And that patient had vague abdominal pain, and because of that it was resected, but it was low-grade malignancy, okay? So the patient had surgery, the patient is cured, okay? Just another example, very similar. Cystic lesion, well-defined, no dilated duct, no nodularity, very sharply marginated on the volume rendering as well as on the cinematic rendering. Again, we talk about looking for septations. Even in the cinematic, I just see one, maybe little tiny septation back here. But I'm still going to think this is probably low grade. But because of its size and the patient had symptoms, it will be coming out. Another example, incidental pancreatic lesion, body of the pancreas, well-defined, has almost like an enhancing wall. I might have given it some thought about a cystic neuroendocrine tumor. I don't see dilated pancreatic duct or common duct. Surely no pancreatic duct, right? It's the body, so it's less likely an IPMN. But boy, you know, the more you look at it, particularly with the volume rendering, it looks like rim enhancement. And could I be dealing with a serous cystadenoma? Unlikely, because of the enhancement around the edge. But yes, MCN, but I really could not exclude a neuroendocrine tumor in this case. And let's do one more, and then we'll take a break. This is a large cystic lesion. No, it's not the liver. If I showed you all the images, you recognize as the pancreas. This is 20 centimeters. Again, serous cystadenoma, but it has thickened wall to it. But it could be. Could it be a malignancy? Could it be liver mass? Could it be a retroperitoneal mass? But this was from the pancreas. This was one of the exceptions to the rule. This was a mucinous cystic neoplasm, thickened wall arising from the head of the pancreas. Based on size, this is malignant, and this was resected, and it was a high-grade malignancy. So with that, let's stop. We've gone through a number of different cases. I want to go through some more cases and make a few important points to share with you. So let's take a break and come back, let's say in 10 minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.